Hello everyone. My lecture is about cardiac markers. In this lecture, we try to state what are the cardiac markers. We will show its types and where their locations are present within the cells. We will simply define what is myocardial infarctions, and we try to describe the latest diagnostic criteria. We will not talk about the medicine, but we will just highlight the criteria and the biochemical point of view. Then we will explain the use of these cardiac markers. Then we'll go into illustration of the biochemistry of these markers. Most important things, we will recognize the cardiac marker in the current use. This is very important to highlight on. Then we will show the kinetic or the time course of these cardiac markers after myocardial infarctions, when they will increase and when they will return back to the normals. This is very important part and should be taken into considerations. Finally, after collection of these information, we are trying to apply these markers in a clinical settings. So, before we start, let's look at this. A patient is presented to the emergency department with a chest pain 20 minutes ago. At the emergency department, they took for him a blood samples, and the result of the cardiac marker were as follows. Later on, the doctors decide that the patient should be kept in the casualties under observations. After 4 hours of their admissions, another blood samples was collected, and the result were as follows. Later on, 12 hours later after admissions, the sample results were as shown. So the questions to this case, what would you choose the most ideal early marker in these conditions? So let's start. What are the cardiac markers? Cardiac markers are simply a laboratory tests that are useful for detecting acute myocardial infarctions, or not necessarily they are used in myocardial infarctions, but they are useful in any myocardial injury. They are most useful when a patient has no ECG tracing, no ECG finding. The cardiac marker generally are located within the myocardium. They are released from the myocardium once the cells are ruptured, and they should be measured or can be measured in the blood. We need a marker that can be measured in blood. Most of the cardiac markers in our practice are myocardial proteins, which they are differ in their distributions within the myocyte. This in turn reflect in their release from the cells into the bloodstreams, which is released earlier and which is released later. So the release kinetics depend on their distributions within the cell, and in addition their clearance from the circulations. The cardiac marker passing through the different developmental stage, starting with the earliest markers in practice, which is the AST. I think you remember that from the lectures of enzymology. It is backdated to 1960s, where the AST discovered as a cardiac marker. Then by the 1970s, the CK and the LDH develops, and late 70s and the beginning of the 80s, myoglobin and CKMB were started to be used. From 1990s, we entered into the era of troponins as the best cardiac marker that can be used and enter into the definitive diagnosis. Acute myocardial infarctions is a rapid development of myocardial necrosis. We will look for these definitions later on. It is caused by critical imbalance between the oxygen supply at one hand and the demand of the myocardium at the other hand. So there is all the time shortage in the oxygen supplies at the expense of the rapidly demanding myocardium. Once the damage has happened, it will be irreversible, especially if the ischemia is prolonged. So let's imagine that this is the artery. This is the lumen of the artery, where atherosclerotic plaque occludes some of part of that arteries. There is inflammation. As the condition progresses, this plaque may rupture, and this will cause releasing of thrombogenic materials, which will attract the platelet and other coagulation factors, which will occlude the arteries. In that case, no flow of blood through these vessels. When this happens, when occlusion to the blood flow happens, the area distally supplied by the artery will be deprived of blood flow, and here the necrosis will be happened. What is necrosis? Necrosis is a cell death that is triggered by external factor of disease. It should be differentiated from other terms, which is the apoptosis, which is normal cell death or programmed cell death. Once the necrosis has happened, all its content, all of the cells will be released into the circulation. The diagnostic criteria of myocardial infarctions are many, but the latest one, dated to 2018, said that the diagnosis of acute myocardial infarction based on detections of rise and fall in cardiac troponin. So the major cornerstones of this criteria is the cardiac troponin, in addition to presence of symptoms, and we will upload a video for you about how the patient will present from our patients. There will be and/or ECG finding, and there may be evidence or imaging evidence of acute myocardial ischemia. When we said rise in the cardiac troponin, this rise should be above the reference range or more than what is called 99 percentile. The question is, and from the clinical point of view, most of the clinicians ask about the ideal markers. That is not present. But what are the features of the ideal marker that they are looking for? First of all, the marker should be present in the myocardium in high concentration and absent in non-myocardial tissues. This is very important to be specific for the heart and nothing else. Second, it should be released rapidly into the blood after myocardial injury. So, once the injury happened, the marker released into the circulation without any delay. The third thing that we need to have in that marker, need it to remain high or abnormal for several days. We don't need to return to normals immediately. Fourth, it need to be assayed within reasonable time, within a shorter time, so that the result will return to you and we quickly make decision. Once the results are returned to you of the cardiac marker, what is used for? The first thing that is useful is ruling in and ruling out myocardial infarctions. Second, confirmed an old myocardial infarction. Third, monitor the success of, and finally, risk stratification of patient with unstable angina. So the main uses are to rule in and rule out myocardial infarction. And to rule out myocardial infarction, we need tests with high diagnostic specificity. And to rule in myocardial infarctions, we need a test with high diagnostic sensitivity. The biochemistry of these cardiac markers. We will concentrate on the main three cardiac markers that is currently used in practice. These are the cardiac troponin, CKMB isoenzyme or isoforms, and the myoglobins. We will see what our opinions about the cardiac enzymes. But is there another cardiac marker? The answer is yes. There is many developing markers in the field, such as ischemia-modified albumin, myeloperoxidase, C-reactive proteins, the brain natriuretic peptide. Let's start with the simple one and the earliest one, is the myoglobin. As you know, myoglobin is an oxygen-binding protein within the muscle, whether cardiac or skeletal. It is low molecular weight protein, and its location is in the cytoplasm. That means it is the earliest marker to be raised after the myocardial infarction. Myoglobin start to rise in the blood after 1 hour or 4 of the onset of myocardial infarctions. It will peak within 6 to 9 hours, but it will disappear within 24 hours. So, by this mean, a negative result from myoglobin will be a good, excellent to rule out myocardial infarctions. So if two samples are presented to us, 2 to 4 hours apart, with no rise in their myoglobin, this will exclude the myocardial infarction. The second marker that is used is the creatine kinase. As all of you know that the creatine kinase is the main enzyme that is able to transfer phosphate between creatine and the ATP-ADP systems. So creatine phosphate is the main backup for rapid ATP regeneration in any tissues. But we are not interested in CK total. What we are looking for is its isoenzyme. As you know, the CK consisting of 2 parts, 2 dimer, M and B. What is interesting is the CKMB part. CKMB is found mainly in the cardiac muscles, and it represents around 10 to 20% of CK activity as totals. There are 2 forms of the CK, which is the CKMB1 and CKMB2. Third, and the most important one, is the troponins. Look at that troponin. troponins are regulatory protein. They are present in the myofibrils, and there are three types of this troponin. The first one is called the troponin C, which will bind the calcium within the myocyte. The second one is the troponin I, which will inhibit the contraction later on. And the third part is troponin T, which is called troponin T because it's a tropomyosin binding component. So what we will important for us is the troponin T and the troponin I. We see that later. Troponin C is not so important in a cardiac marker. Does the troponins are specific to the cardium? The answer is yes. Because the troponin that is synthesized within the myocardium is different by additional amino acid sequences. For example, troponin I has additional 31 amino acid sequences, while troponin T has additional 11 amino acid sequences. Most of the troponin is attached to the myofibrils, with a smaller part will be present in the circulations. But in some conditions, such as muscle diseases or end-stage renal failure, some of the diseased cells can synthesize a similar protein to troponin that can interfere with the assay method and cause an increasing level of these proteins. So be cautious when a patient presents you with end-stage renal failure, and don't use troponin T. Nowadays, new terms have been appeared, which is high sensitive troponin. Actually, this is not a new troponin. It is the same as the troponin that we discussed. But what's new about this is the method of dissections, because previously we cannot detect levels of troponins that is present in normal populations. Nowadays we can do that, and troponins may be found in normal populations. So the fifth generation of cardiac troponin assay can detect troponins 100-fold lower than the actual method that is available. In addition to its higher sensitivity, it also will be realized in the myocardial infarction earlier than the conventional troponins that we said. So it can be used if the level is low and remain low, it's not changed within the time, can rule out myocardial infarctions. So now, from all this list of the marker that we said, what we should use? Stick to the three: CKMB, cardiac troponins, myoglobins. Is there any futures? The future is coming, and there is many others such as fatty acid binding proteins, glycogen phosphorylase, and the others. But what about these? What about the enzyme, cardiac enzyme? The answer is the cardiac enzymes are obsolete nowadays. So nobody do in practice cardiac enzyme. Now, this is the critical slide, and you should understand it carefully to interpret the result of others. This slide shows the kinetic of cardiac markers. When does the marker will be increased? When it's peak and when it's disappeared from our circulation. So the first one, the myoglobin, is rise 1 to 4 hours, within 1 to 4 hours. So this is the earliest one. Peak within 6 hours, we reach to the peak, and disappear within 24 hours. So if the patient presents to us after 24 hours of the onset of his pain, we don't find any rise in the myoglobin. CKMB also forms to arise later than that of the myoglobin, 3 to 12 hours, after 3 hours, and peak within 12 hours, and remain for 2 days, and then disappear. The cardiac troponins release from the myocyte or dead myocyte later because they are attached to the fibrils, so they are difficult to detach, and they remain elevated in the blood for or peak within 24 or to 12 after 12 hours, and remain elevated for 5 to 15 days. So this is very important if we receive the patient after 3 days, for example, of his development of the chest pain. So we can know that the patient had an infarction. This graph simplified how the changes will be happened. I just mentioned here the enzyme just for your interest, just for your knowledge, but we still keep the use of only these 4 markers. So the earliest marker will be myoglobin, together with the new one that has appeared these days, high sensitive troponin. They are sensitive, but they are not specific for the myocardium. While the troponins, their rise after the onset of chest pains will be late, but they are more specific for myocardium. Finally, whatever the method that you are using troponin or the cardiac markers, they are either use the most sophisticated one or we use the point of care one. Sorry.